So, welcome back to Above the Noise. It's my honor today to welcome a friend that I met just this year. Her name is Dr. Agnella Chingwaro, and she is serving in the country of Indonesia. And her story is very powerful. I think you're going to love it. It's, it's going to be encouraging and inspiring the work that she's doing. Welcome, Dr. Aggy, to our podcast.
Thank you.
So introduce yourself to our audience. Tell us a little bit about you and your family and what you do so that our audience can get to know you before we get into the work that you do and the ministry that you do.
Thank you so much for having me today. My name is Agnella Chingwaro, and I was born and bred in Zimbabwe in Southern Africa, and I'm the youngest of 9. We're 9 siblings.
Are you married?
I am married to a Papuan Indonesian. My husband is Papuan.
And how do you have any do you have any children?
Yes, we do. I'm a grandmother.
A
So
grandmother, okay.
I have one granddaughter, Anaya.
Yeah, great. Thank you. So how did you get to Indonesia from Zimbabwe?
It started during the HIV epidemic in Africa. So we were working in the government. That's when we were asked to also go to the churches. And I'm a Lutheran. Being a Lutheran, the Lutheran church has a lot of hospitals from where I come from in Zimbabwe. We have Lutheran hospitals. And then we were working with the Lutheran World Federation doing HIV outreach programs and helping people living with HIV. And then from there, that is when we started to encourage the church board to have infectious diseases control clinics in each and every church facility, church hospital. And then from there, we started growing, and I started going from one country to the other, working in the same mission with the same organization as well, the faith-based organization, because my country is a Christian-dominated country, and we have a lot of churches. And in those churches, there were a lot of people infected with HIV, and there were a lot of deaths being recorded. So we needed to break the silence from within the church. So that's how I started. And then from there, I went to Botswana, and I was also working with Evangelical Lutheran Church in Botswana. So that is when my bishop, by then, Bishop Reverend Cosmos Moenga the late, when he went to the meeting in German with the United Evangelical Mission, is the mission partners. That is when they met the bishop from Papua, from the Evangelical Church in Papua, and they were talking about the HIV issues in Papua and in other mission partners. So when my bishop was retelling the story of how I managed to handle the HIV cases in the church, that is when the bishop from Papua, Reverend Bishop Pendeta Yemi McRae, that is when she also asked if my bishop could send me to Papua also and maybe help them with the issue. So when my bishop came back from Germany, from Wuppertal, and then he was asking me if by any chance I would see myself working in Papua, Indonesia. And by then I didn't even know where Papua is. So I had to Google Papua, Indonesia. And what I saw, I was like, okay, how did HIV get to this part of the world? So I was so curious. At first it was curiosity that drove me to Papua. And I was only told it's a 3-year term. And for me, it was okay. And then I signed up for that. And that's when I came here to Papua. I was with the Evangelical Christian Church in Papua that is called the GKI, meaning in Indonesian it's Gereja Christian Injili di Tanah Papua.
Thank you for that introduction and how you got to Papua New Guinea. So where did you begin your medical training?
In 1999.
Where
I
were
finished
you
in
in Botswana
1999.
or in? Pardon me?
In Zimbabwe.
In Zimbabwe.
Yes.
So you became a doctor in Zimbabwe. You were working there and then you came over as a doctor to Indonesia. Were you always in family practice, or were you in infectious disease?
Infectious diseases.
Infectious diseases.
Yeah.
Tell us a little bit about your faith journey, because, as you said in your introduction, you're working with Christian organizations that brought you to from Zimbabwe to Botswana to Papua. And so tell us a little bit about your faith journey.
Yeah. I was raised by a very, very traditional Lutheran family. My parents were very, very traditional Lutherans. And from there, the way we were raised was mainly, and I used to see my parents helping other people and always doing in Zimbabwe, where I come from, in Mashonaland Central, there are times when we have drought, where there's no rain at all, and there will be shortages of food. And my great grandparents were farmers, so it was passed on to generations up to my father. So they are also farmers. They were also farmers, and whenever they had food, and during the drought period, they would share their food with other people. But they would not just go and dish out the food to the communities. They will invite them and share the word of God. They pray together. After that, they will share the food. It really encouraged me also to do that. At the times, my mom would be busy doing some other things, and then I'll be helping my grandfather to do that, and my mom, my dad, I'll be helping him also to do that. And during that same process, some women would bring their malnourished children, very sick children, you know, and how were we going to help them? Usually they would have diarrhea, and then my grandmother would say, just boil some water and put 6 teaspoons of sugar and 2 teaspoons of salt for dehydration, and then you put in a liter bottle and you give them. So
Hmm.
that has sprouted the passion in me to help other people just by doing the sugar and salt solution for dehydration. So I felt very proud each time I would go and follow up, like, how is your baby today? Is your baby still having diarrhea? They'll say, no, after giving them the sugar and salt solution, it just stopped. And they're doing much better. So it encouraged me also to do more, to wanted to do more. So that's when my grandfather said, I pray that one day you'll become a doctor. And then I fulfilled my great grandfather's wish.
That is a great legacy to be passed on to you, and to plant that seed in you to become a doctor. The
Yeah.
example of your parents in serving others and finding that simple solution to a problem that is all over the world. The sugar and salt solution to help children with diarrhea can save
Yes.
so many lives. So did you ever think about becoming a missionary? Or even when you came to Papua, did you see yourself as a missionary, or you were just coming as a doctor to serve for a little while?
Not at all. I never saw myself as a missionary. But when I was working, before I came to Papua, that is when I realized that if I remain within the government shell, I would not be able to reach out to more people.
Mm,
So it made me want to break away from being a civil servant into a missionary, because whenever we go to the church facilities, you find a lot of people, they will be there as compared to the government facilities, because they
mm,
knew when they go to the church facilities, that's when they are going to get the help, be it with food, be it with clothing, whatever, shelter. Even
mhm,
during disaster times, the church will be in the forefront, especially the Lutheran World Federation and other church organizations, the Christian Council churches. They will be in the forefront during those times. The church had an upper hand in gathering a lot of people, whether they have problems or not. So that's when I made a decision that no, I think I should come out of this shell of working in one institution and go on a broader um, practice, working as a missionary.
when you came to Papua, then you had already made that transition to be a missionary because you started working with a church organization back in your home?
When I came to Papua, that's when I immersed myself into becoming a missionary. That's when
Okay.
I found the real meaning of being a missionary.
What did you find out that meaning to be when you got to Papua?
The situation that I've been working with in different parts of Africa is totally different from here. And the approach that we used to do in Africa is totally different from here. So in Papua, there are so many aspects that we look at. It's either it's emotional, it's political, so they are very sensitive. And I would always wanted to use the faith approach. And Papua is not only Papua where you have the Christian community, it's a multi-denominational community. There are so many faith denominations here. So it's very difficult. So it made me strengthen my practice, like, I'm focusing on being a missionary, and I'll be working mainly on different faith denominations. How am I going to do this? Because I'll be facing the Indonesia is an Islamic state, and it is Hindus, it is Christians, and other denominations. So, and all those denominations, they are also being faced with HIV. And when we talk of HIV, it is no culture, it is no language, it is no faith, it is no race, no color, no language. So all those that are infected, I needed to embrace them in order to be able to tackle the problem. So that's when I rooted myself into becoming a missionary. How do I work within the Islamic community? How do I collaborate within the Hindu? So Papua really strengthened my mission as a missionary here, that yes, I'm going to be a missionary.
So let's talk a little bit about the AIDS epidemic and the AIDS situation, because that is your specialty, that where you're working. As we begin, give us a comparison between the AIDS epidemic in Africa and then what you found when you came to Papua. Was it similar? Was it different? And how was your work either similar or different from what you were doing back then in the AIDS community?
Yeah.
It,
Thank you. It's very different in the sense that in Africa, when we talk of HIV, our people quickly understood it, and they quickly realized that we were perishing. The people were dying, and we would speak the same language and understand each other. And they would come forward. And during the early days of HIV and AIDS, there was a lot of stigma. But when our people got more education on that issue, they quickly understood it, and they quickly changed their way of living. For example, in my own culture, when a man dies, he leaves behind a wife. And that woman, that wife, they might have paid full bride price, and they have children. And the family from the deceased man would not allow the woman to go back to her own village. They would arrange for somebody to remarry that woman. So it went on and on and on and on. So the moment there's an inheritance, even marriage inheritance from my own culture, a lot of people were dying because the widow will be infected with HIV. And they find a replacement from within the family or from within the extended family to inherit, to remarry that woman so that she doesn't go away with the wealth from the deceased. And then within 2 years, that same man will die again. And that same woman would want to bear children for the new husband. And that child would automatically die again. So we realized that this was becoming a problem, and we addressed it, and the people understood that. So when I came to Papua, it was it is still a different issue, that we have over 300 languages here. in Papua. Even in Jayapura, there are a lot of languages. You go from one district to the other, there's a different language. So although they speak Indonesian, but the different languages, different culture, different beliefs. So it's very difficult to penetrate in those different beliefs and different cultures as compared to Africa, where they have they can be Shona speaking people with different dialects, but they are Shona people when talk of Zimbabwe. But in Papua, they can be Papuan people, but with different languages, different culture, different everything. So it was building a very big wall, and it is still a very huge difference in order to be able to tackle the HIV issue. So the main difference is when we are talking of HIV in Papua, we have to have a certain type of approach. You can't just say, yes, you are here, I'm testing you for HIV, and because I'm suspecting you this. Because they will feel offended. Like, why would you say I have HIV? Why would you want to test me for HIV? And then the next thing they would, some of them would say, I don't have HIV because I don't have multiple sexual partners. I am sick because maybe somebody did something to me, the black magic or something like that. So in comparison to Africa, they quickly understood that. But in Papua, we are still working on that. And also, once you test for HIV, it's not like when they are still very healthy and you screen for HIV, it's difficult also to gather them up and say, let's do this and we are going to do the HIV testing. But they would want to present themselves to the medical facility while they are already sick or in AIDS condition. So we'll always encourage them to come forward for testing while they are still healthy, while it's still just HIV, not AIDS. So when you talk of Africa, in my own country today, if somebody feels uncertain with the condition, he or she will just go to the pharmacy and buy the oral swab for HIV. And she does it herself. It reacts positive. She brings the same swab result to the doctor, whether she wants to go to the public hospital or to the private hospital. She brings it and said, I swabbed myself and this is what I got. So we no longer close windows and doors and do the counseling. People just bring themselves forward as compared to Papua. So in Papua, it's just a one-way gate. When you want to test for HIV, it's either you go to the public clinic, the government-owned clinic, or the government hospital, or any other private hospital. That's when you go and have the HIV testing. Or you go to the private laboratory and you test for HIV. But if you are tested for HIV from a private laboratory, it means you are going to go back to that same one door that is the government facility, because it's a subsidized program from the government, of which the medication is for free. So once you go back there, you're going to be registered, your identity and everything. So a lot of people here, they feel inferior that they've tested for HIV and they are positive. And they wouldn't want to go to the public hospital or wherever they are going to be registered with their identity cards. So we are facing a huge problem with that. They don't want to be registered. So there's an application, the whole country. So once everybody is tested for HIV, they are registered into that application. And it's known the whole country that even if you go to any medical facility, you want to top up your medication, you can just top up because you are already registered. So a lot of people do not want to do that. They don't want to be registered. Hence, they decide to refrain from treatment.
They don't want to be identified.
They don't want to be identified.
So
they
let's
don't
do a
want to be
clarification
identified.
here. There's two clarifications I need to make. When I first began, I said Papua New Guinea, and you're not in Papua New Guinea, you're in Papua,
In,
Indonesia. They're two separate countries, two separate places. So that's my
yes,
error, and I stand corrected. You are serving in Papua, Indonesia.
yes.
Other question is, can you explain to our audience the difference between HIV and AIDS? Because you're making a distinction between the two. From your medical perspective, what is the difference?
The difference is HIV is not a disease. It's just a virus that got into somebody's body. And the function of HIV, in simple terms, it is there to destroy the immune system that protects a human or that helps fight infections, the immune system. So once the immune system is compromised, that's when we start to have AIDS. And what is AIDS? AIDS is comprised of opportunistic infections that we are always facing on a daily basis, like TB, meningitis. All these diseases have been there a long time ago. But because our immune system has been compromised by HIV, we can no longer fight it on our own like we used to do. So when somebody has TB without HIV, they can be on treatment and it's okay. But if somebody has HIV and gets TB, it becomes a complication. And also they can also have meningitis, they can have any other ailment, of which such ailments, that's what we call AIDS.
Okay.
HIV.
The distinction there is early detection, if I hear you correctly. And
Yes,
one of the battles you're fighting in the culture there is early detection. People don't want to be tested, they don't want to be detected early, if I hear you correctly. So
yes,
then by the time you get to see them, they're already in full disease
blown
mode,
AIDS.
which makes your work much more difficult.
It makes it very difficult and very expensive considering where we are. In Papua, we are in a resource limited province. Papua is very big, very huge, and geographically it's a difficult to reach area. It's very mountainous, and there are some areas that are very mountainous and waterlogged areas. So everything that we have here is ordered from Jakarta or any other province outside Papua. So it will be very, very expensive to treat AIDS rather than testing early and identify the HIV or diagnose with HIV and treat, put on antiretroviral therapy before getting sick. So once they
Mm.
get sick or once they become fully blown with AIDS, the treatment is so complicated. And at times you try to treat somebody is having meningitis, having TB, and where once they're having TB, the TB becomes a multi-drug resistant TB because they at times they default treatment whilst they were taking the first category of TB. So there are a lot of issues that happen.
Mm.
Yeah.
So, is there a difference in AIDS between men and women? Most of your parents, male or female, or it's evenly distributed? And also children. Let's also talk about the effect of AIDS on children.
Yeah. We have children born with HIV. It has a huge, huge impact on them because when they are born with HIV, it means the mother, when she was pregnant, she either didn't go for HIV screening or she didn't go to antenatal care while she was still pregnant. So it's a World Health Organization standard that every pregnant woman gets screened for HIV, hepatitis, syphilis, and malaria. But some women, because they are living in out of rich areas or where they do not have access to medical facilities, they would be pregnant and prefer having a home birth, and they are being assisted by traditional midwives. And those traditional midwives, some of them, they do not have the knowledge about a woman being HIV positive and transmitting the virus to the baby, and also them being at risk of being
And
infected. So in this case, when children are born from HIV positive mothers, we usually want to give them prophylaxis, but if they are out of reach, we do not get in contact with them. So now those children, it's either they don't reach the age of 5.
Early mortality.
Early child mortality, yes.
So let's go back to the first part of my question. Have you seen, is there a difference between men and women, or is it pretty evenly distributed among the
Yeah,
male and female population?
it's we have a lot of female, it's not equally distributed, and a lot of women here, they are infected with HIV. But when we talk of HIV, we talk of two individuals having sexual contact. So it's either that woman has been tested for HIV and we did not do the partner contact follow-up. Usually, especially, it's a mandate that when somebody tests positive for any communicable disease, we do the contact tracing. So at times they might have multiple sexual partners, and sometimes they feel really bad about exposing themselves that they had multiple sexual partners, of which they would prefer just to identify one, or they'll say, no, we already divorced, or I don't have any partner, I'm living alone. So we cannot, ethically, we cannot push a certain individual, say, just tell us whom you have been in contact with. So gives us a huge number of women with HIV other than men. Not because men are not infected. Men are also infected out there, but they do not come out in the open as women do.
Mm. Yes, we have a similar issue here in the United States with men not wanting to go to the doctor
Yeah.
until their symptoms are being expressed. I have another podcast which I thinking about also sharing this on, called Real Health Black Men. And the purpose of that podcast is to help men, primarily men of color, come to grips with the need for early detection and early screening to prevent some of these diseases, so that they don't wait until they have pain or their full-blown disease to show up at the doctor. So when I met you, a couple of things I want to say here. When I met you, I was in Papua with an organization called Mission Aviation Fellowship and doing some work with them. And you were talking about the remote places where it is. And sometimes it's hard for people in the West to understand when you talk about remote places. And I got to see that for myself. Papua is a large country, and some places are only accessible by foot or by canoe, or
Yes.
sometimes people are walking days to get there and walking back, very remote villages. And what Mission Aviation Fellowship does, which I had an episode with their CEO last summer, is to provide airplanes that get people to these remote villages, people like you and teachers, doctors, nurses, supply clinics in these villages with medicine, and teachers with supplies, so that these people in remote areas can get access to medical facilities. But when we talk about medical facilities there too, we're not talking about the Mayo Clinic. We're talking about a clinic in a small clinic in a village that may be serving people from hundreds of miles around, right? It's something that's hard to imagine
Yeah.
unless you've seen it.
So it's very true. Even if when you go to the remote areas, when you talk of remote areas, we talk of an area where the Cessna airplanes or the Piratos airplanes, when you miss the time, like if you go after 10, they would say we cannot get there anymore because it's too windy. We
Mm-hmm.
we risk, having, a plane crash. And at times they will drop you somewhere and then you have to walk on foot. Maybe for a person like me, I would walk for 5 days. But, by God's grace, we managed. There are a lot of obstacles that we encounter, and this is a tropical region. There's a lot of rain. There's a lot of rivers, flowing rivers, not just rivers, flowing rivers, and the thick vegetation. So we manage, and A lot of people who are called to serve, they don't look at that. They just move forward. So I'm proud to say that I am one of them. I once went to a village in the highlands called Kurima, and the car just parked by the riverside, and the river is called Yetni, and you don't see the water flowing. It flows from underground, and you just see the sand on top. But they would say, if you misstep, you are going to drown in that sand. So the people who knows the way, they will lead you. And we were following their footsteps and going through that river Yetni. And I managed. Where I come from, I don't have mountains. I never climbed the mountain, but I did here. So then I said yes. So this is a
Uh,
calling. Yeah.
all of that just to deliver medical care to a village.
Not only
Wow.
not only to deliver medical care, there will be people there. When I first came here, I really wanted them to know about HIV. I really wanted them to know that there's still life after being infected. When we do the outreach programs, we will do the testing. Maybe I'll go there for 3 weeks or even a month. And they will be knowing that, oh, the team is coming from the church. They are coming. And the women will be waiting for us up there. So after
Okay.
doing the outreach program, the testing and everything, that's when you feel good, like, yes, all this climbing and crossing of valleys, it really paid. People now know that there is HIV. People now know that they should test. People now know that they should be on treatment. People now know that they should adhere to their medication once they are on treatment. So
So
it was,
you're bringing hope to
yes,
people. Yes,
yes,
bringing hope to people. So
yes,
one of the things you told me about in our first conversation is that one of the developments you've done since you've been there is you started to create, is it health educators or people that you're training who can go out sometimes with you or ahead of you into places to help with medical education?
yes. We are still doing that. And I think you know the situation uh, in those remote areas here in Papua, where there are conflict regions, conflict areas. So a lot of medical personnel, they have been evacuated from those areas. So we realized that now that the medical personnel have been evacuated, they have gone back to their respective cities or villages. So nobody is there. So we decided to train the community healthcare workers. So when we train them, we are training them so that at least they start to educate their own people, and they build bridges between the community and the only surviving clinic that is available, or the hospital, the nearest hospital that is available. So we train them to do the malaria testing. We also train the traditional midwives to do the HIV screening for pregnant women. We train them also to be able to identify risk pregnancies and avoid obstetric fistulas amongst women and young girls who are pregnant. So they are doing a really quite a tremendous job. And there are some areas where I cannot go. But those community healthcare workers we trained, they are from those regions. They speak the same language. They have the same culture. They understand each other. So once we train them, we equip them, and they are the ones who are going to represent us there. So they're the ones who are going to do the job, and we are just monitoring them. So it's quite a blessing that now they have access to internet. We can communicate. And just 2 days ago, one of our traditional midwives had a complication with the placenta, and she was confused what was she going to do about it. It has been almost 3 hours, and then she decided to call, and it was a video call. And then we managed to help her to save the mother and the baby. So it's something that brings hope that, yeah.
So you're doing telemedicine in the
Yes,
remote villages of
yes.
Indonesia
And
using satellite phones and computers.
yes, can you imagine? One of our, I think we have almost 15 traditional midwives, And those 15 traditional midwives, they cannot read, they cannot write. They cannot even speak Indonesian. They're the indigenous people. But we managed to communicate. I don't know how.
Mm.
The work of God. I don't know how. Yes, their Indonesian is not clear and I cannot understand them. They cannot understand me. But we work together. We understand each other.
You do it over the computer, over
Yes,
video call. That is amazing. That is amazing. The technology is being used
yes,
in many positive ways. One of the
yes.
things we also talked about was the effect of AIDS on children, and you were sharing me the story of the two children you adopted. Do, would you mind talking about that?
Yes, sure. One of my daughters, I met her parents when they came to the clinic for HIV care. But unfortunately, we couldn't save them for a long time. The father was on treatment with me for almost 6 months, but he couldn't make it. And then after that, the mother also was very sick, and the baby was almost 3 months by then. And she managed to live for almost 2 months, and then she passed on. If I may bring you back a bit from my practice at the clinic the clinic that I'm running for HIV and AIDS care, we have an ambulance and nobody wants to drive HIV positive people, even dead bodies, they don't want. So they are afraid of it. So I was the ambulance driver, even if there's an emergency that I would need to rush to the hospital for some procedures or something else, or if there's a death, I would need to bring the dead body back to the family. So it was just me and my nurses. So we were just a team of women, but still we couldn't find a driver who would want to drive dead bodies, HIV/AIDS dead bodies. So it's discriminatory. They don't want to do that. And so when I brought the body of the mother, and then I said, I have the baby too. And the relative said, is the baby HIV? Then I said, not yet. We cannot diagnose HIV yet until 18 months. And then they said, we cannot accept the baby because we have other babies here. We are afraid that baby would infect other babies. And the body also was not allowed inside the house. So we brought the body to the gravesite and then we brought the baby back to the clinic. So bringing up that child at a facility where she sees a lot of people suffering. And although the nurses were so loving and everybody loved her, even the other patients loved her so much. And she was such a bubbly little girl. And then I realized, I spoke to my husband. I said, I think the woman in me does not allow this baby to be raised in such a facility where every day she sees very sick people. Because at our facility, we do not take care of walking patients, very, very sick, bedridden AIDS, fully blown AIDS cases. I didn't want her to see that. And then we agreed that we bring her to our house. And then that's how she came. And then after 18 months, we did the dry blood testing for HIV detection. And then, yeah,
So she's now your daughter.
she's now my daughter.
She's now your daughter. So
Yeah.
you didn't just rescue her from the hospital. You adopted her.
Yeah. And then,
Yeah. And I got to meet her. That was great.
yes. And then I said, let God's will be done. So until
Okay.
now, she's in junior high school.
Great. And
Yeah.
growing strong.
Yeah.
So what are some of the myths about HIV and AIDS that you would like our audience to understand?
Yeah, there are a lot of myths about HIV, and a lot of people would think that HIV is a curse, whereby when somebody has HIV and transmit it to the wife and other people, they would think, yeah, it's a curse from God.
A curse. Yeah.
Yeah, that's what they think. And some would think that HIV is transmitted through sharing utensils, like sharing the same cup the same plate and sharing the same clothes. And you'd find that when somebody dies of AIDS, they have a tendency of burning the clothes. So at times I would say to them, just wash the clothes and iron them, and you continue to use them. You don't have to. And at times when I'm doing my outreach programs, I would ask them, like, have you ever been into a department store where you want to buy your trousers or your dress or something else? They said, yes. Have you ever fitted that trousers, tried it on? They said, yes. And have you ever asked the shopkeeper that, has this been tried by somebody with HIV before I tried? They said, no. Then I said, so how would you know that somebody came and fitted it and tried it? And, was that person HIV positive or not? They said no. Then I said, it's the same. So we are getting there, but slowly through education. So, and at times they would think that HIV is transmitted through malaria bites, mosquito bites. So they would always ask, like, since mosquitoes, they bite people, and if it bites somebody with HIV, is it going to transmit to the next person? And then I'll say, if that is the case, then the whole world would be HIV positive. Malaria, mosquitoes, they only transmit parasites. They have parasites, not viruses. And at the same time, when a mosquito bites somebody and there's the blood, it does not spit the blood back to somebody. So it just bites. So there's no HIV transmission there. So there are a lot of people think that HIV can be cured. That's how they think. Yes, we tell them that we can cure AIDS. AIDS can be cured. AIDS can be totally be cured. But HIV can be suppressed. We suppress the virus through antiretroviral therapy if taken as prescribed. When now we have advanced testing for HIV monitoring, where we do the viral loads, we do the CD4 counts. So once we do the CD4 count and the CD4 count is higher, and then the viral load is suppressed, and then it says the end result for the viral load, it says undetectable virus. So that message of saying undetectable virus, when it's conveyed to a certain individual whose understanding is limited, they would say, the nurse or the doctor said my virus is undetectable, which means my virus is gone. And then the next thing, they don't want to continue with their antiretroviral therapies. So once they stop the antiretroviral therapy, when it comes back fold, and it's very aggressive. And then people would say, you are faking us. You are saying there's life after being HIV positive. If you take your medication, why is it that our son was on HIV treatment, was on antiretroviral therapy? And when he went to test, they said the virus is not detectable. And we stopped medication. And then he got very sick and he died. Why? So we still have to explain again, and education again and again and again.
People begin to feel better and they stop taking the medication.
Yes.
Which creates the opportunity for the virus to come back. Yeah.
To come back again.
There's so many similarities with people that we talk to here as well. People say, well, I feel better. Why do I have to take my medication?
And there's some they would say, they'll bring back the medication.
Yeah. Humanity, no matter where they live. Yeah. So what are some of the greatest needs in your ministry right now?
Some of the greatest needs in my ministry right now is that I still want to continue to train the people. Now we are having a problem with internally displaced people from conflict areas. And whilst they're in those shelters, they are not, being monitored. So there are a lot of things going there. Teenage pregnancies, circulation of infections. So I still want to reach out more to them and train some of the active people within those communities so that they do the health awareness within their communities where they are displaced. So now we are having an influx of people having communicable diseases, but they don't even know how to deal with that. In those areas where they are as displaced people, it's not easy to reach those places, but we can access them. Just like a few months ago, we brought in about 30 participants, 15 men and 15 women. We train them. We train the midwives. We trained some to do the screenings and stuff like that, so that they'll be able to do the health education within their communities where they are. So that is my major need for now. And at the same time, we want to upgrade our testing equipment, especially our laboratory. Would want to upgrade it, so that at least when we are doing all these outreach programs, we bring our equipment with us, so that when we get there, we wouldn't say, oh, we wish if we could have brought this, or if we had this, we could have helped this person. And mostly we would have 100 plus people who are gathered. And if I ask them, do you really want to know your status? Do you really want to know what's happening in you? And then they would voluntarily say yes. So we'll do the HIV testing, we do the syphilis testing, we do the hepatitis testing, we do the malaria testing. We also screen for leprosy, we screen for TB. But then we do not have portable equipment that we could bring with us. So it's a major obstacle that most of the times I would see their signs and symptoms of leprosy. But then I would want to know more, what type of leprosy does this person have that would really, make me do the right decision, the treatment. How am I going to deal with it? I want to test the morphology. I want to investigate more. We have portable machines, but we do not have that. We have TB. I can't just go there and say, yes, you are having signs and symptoms of TB. And then I will say, I'm going to access anti-TB drugs for you. It's very dangerous, because most of the times they might be having multi-drug resistant TB. So we are not doing any good, but we'll be doing more harm. So that is the major complication that we face when we are in our outreach programs, in our ministry.
How do you get medicines and equipment for your ministry? Are they supplied by private parties or supplied by the government, or is medicine easily available where you are?
Yeah. So when we talk of HIV and TB and leprosy, those drugs, they are only supplied by the government. So we work together with the government. Our organization works hand in hand with some government hospitals from the areas that we are working. So once we are, for example, when we are going to a certain district, we go to the district medical office, and then we tell them that we are coming here for A, B, C, D, and then they will tell, okay, if we have some cases like TB and HIV and stuff like that, we are going to report to them as well. This is what we have found. So we would want to have some medication, and then they will access it to us, and then we redistribute to the people in need. So there's
It's, it,
no organization that can afford to buy antiretroviral drug for the rest of a certain individual's life. Only the government can access it. But the government cannot go door to door like we do. The government does not go to the churches like we do. So we are also working on behalf of the government to reach out to the people in need. And then we report to them. They supply us, especially with TB and HIV drugs, antiretroviral therapies, and leprosy drugs. They supply us, and even the malaria drugs, at times they supply us. But when you talk of the reagents for testing, at times they do not supply us from the organization and other donors. That's when they support us with that, because we would need the reagents to do the testing.
what about equipment? The testing equipment you said, like the mobile lab and stuff like that. Does that come from the government too, or that comes from private donation?
It comes from donations. It comes from donations. Like I said before, we would want to upgrade that, so that for now we only have an in-house lab. So when you have an in-house lab, when you go to the highlands, to those remote areas, you need portable machinery.
But that portable machines are available. You just need people or companies to donate them to the
Yes,
ministry.
yes.
So what are three things that you would like our audience to take away from this discussion?
I would like our audience to know that when somebody is faced with compassion, it drives away shame. That when we are compassionate with others, regardless of their condition, and that discrimination also kills people's will to live.
Hmm.
I'm sorry.
Don't be sorry. You're doing important work that's very heavy, and you're saving lives every day.
It's not easy to see people suffering, but it's easy to talk about it. And when we join hands, when we talk about it, when we speak up, at times when people speak up, they will be misunderstood. Am I exposing something? No. We are trying to reach out. This is our way of saying we have a problem. People are dying. And some, they die before they even get tested. They die before the medication reach out to them. So we at Gerat, we are trying. We are not alone. There are a lot of people doing this, a lot of people working towards this problem of HIV and communicable diseases and other communicable diseases, a lot. But we are failing.
Mm.
We are failing. At times we fail because we do not have resources. At times we fail because the people who are called to save, they also need to live, which means for them to be able to work at an organization like me, they don't have any security like pension and stuff like that. So they would prefer to go and work for the government where they are not able to travel the way I do. They will be working within a certain place. So we lose a lot of experienced personnel because working either within the church or in private organizations like I do, they feel they do not have any surety for their future. But when they are working for the government, they have pension, they have a guaranteed salary. So for us, when we do not have donor funding, which means we are going to cut our personnel, or we are not going to be able to do many other things. So those are the insecurities that we have. Yeah.
Well, thank you for sharing that with us and with our listeners. We be praying that God provides the workers, provides the resources, provides the donors and the local staff to work with you and with your clinic to continue to save lives. What is the name of your clinic?
It's Gerat Papua,
How do you spell that?
Jerat Papua. Gerat Papua means Jaringan Kerja Rakyat Papua, the Papuan People's Network. It works with the indigenous people.
It means the Papuan People's Network.
Yes,
And you're located in Papua, Indonesia.
yes, in Jayapura. But I'm in Jayapura, but we work in all corners of Papua where we are needed, where we have access, we go there.
Mhm.
Yes.
Okay. So, what is the best way for people to get in touch with you? Is it by email, or do you have a website or ministry contact?
Personally, I would prefer to be contacted through email. because I am very much afraid of social media because I deal with very sensitive issues and I wouldn't want to be caught on the wrong side of posting very sensitive issues. And like I told you before, people here in Papua are very, very sensitive. And if there's one thing that I want to install within the people I serve is trust.
Mm. Maybe the best way for people to get a hold of you, maybe to send an email to me
Yes.
at my email address for this podcast, above the noise 24 at gmail.com, above the noise 24 at gmail.com. And then we can get that information to Dr. Aggy and to her team and get back to you because we would not want to compromise the valuable and critical work that you're doing.
Thank you.
Huh. So before we close today, is there anything else that you would like to share with our audience?
As emotional as I am, we are having a lot of youth, the young generation, the forgotten generation. They're the ones that are now suffering from AIDS and living with HIV. And the reason why I said the forgotten generation is because when I came to Papua, maybe they were still babies. And nobody thought that those babies will grow up and want to be adults and experience life like other adult people. So we've only focused on the middle-aged. And then when we came back again now, it's the 30 and below that are now highly infected with HIV, and we have a problem of alcohol and drug abuse. So we also would like to start a shelter for rehabilitation for alcohol and drug abuse, and also a youth-friendly center for the youth so that at least they have a safe space where they can express their feelings. Like we talked about HIV, if they see the HIV problem within their families, their parents are HIV infected, it has social, emotional, economical impact on those young generations. So it is also something that gives me sleepless nights, that each time as I finish this, I'm going to go out again and meet them door to door. And some of them, their parents have already died and they are living by themselves. And how are they surviving? I cannot bring every child in my house, but we need a safe space for them. So it's painful that some, they don't go to school anymore. They're in the street, especially the girl child. It's very vulnerable. Just look at them. How best can we help? We are not okay. They are not okay.
You give us much to think about, and then you give us much to pray about. And one of my prayers is that maybe the Lord will touch the heart of people who listen to this episode and move upon them about how they can help, how they can participate, and even not minimizing the power of prayer. And if all that people can do is prayer for you and for your team so that you'll be safe and that you'll have the resources, the strength, emotional, physical, mental, spiritual strength to continue the ministry. And we
Yes.
will pray for that dream of yours to build a community center for these forgotten youth so they have a place to come.
Yes. Thank you.
Thank you very much for the time you spent with us today. Thank you very much for being vulnerable and sharing the work that you're doing. It is not a work that many people would want to do or many people are cut out to do, but it's clear that God has called you to do that work. And I'm thankful that you're doing it. And I'm thankful I got the opportunity to meet you. And I'm thankful that today many of my listeners will also get the opportunity to meet you and see the work that you're doing. Thank you very much.
Thank you.
Thank you very much.